I am the new chair, as you can see, of this body. I'll start by introducing myself. I am Councillor Tahmina Salim. I am the leader of Luton Borough Council. And it's only fair that since I've introduced myself, that you should all introduce yourselves too. So we'll start on my right, or left rather.
Good evening, I'm Kate Robertson. I'm Corporate Director for Population Wellbeing at Luton Council.
Paul Wagstaff, Director of Education, Luton Borough Council.
Richard Underwood, Chair of the Health and Social Care Scrutiny Review Group.
Bev Davis, Partnership and Engagement Manager at Beds Fire and Rescue.
Hello, Michelle Bradley, and I'm Director for Elf Mental Health and Disability Services.
Pat Latimer, CEO of Healthwatch Luton.
Bill Turner, Chair of Healthwatch Luton. Thank you. I'm Peter Chibber. I'm the Corporate Director for Children, Families and Education at Luton Borough Council.
Thank you all. Are there any apologies for absence?
Thank you, Chair. Apologies for absence has been received from Maria Wogan from the ICB, Georgie Brown, ICB, Mark Fowler, Luton Council, Kelly O'Neill, Luton Council, Jill Britton as an attendee but will be appearing online, Stephanie Simone from the CAB, Claire McKenna from the ELFT, but as she's a name substitute, so we've got somebody else, Michelle, and Melanie Banks has given apologies as well from the hospital, but Kathy Jones is here. Thank you, Chair.
So we're going to look at the minutes from the 8th of April. Do you approve the minutes? Are you happy for me to sign them as a true record? Is that a yes? Thank you. Are there any disclosures of interest? Oh, we've got someone online as well. Okay. We didn't do introductions online. For those who have joined us online, and there are quite a few of you, could we take some introductions from you, please? Feel free to start.
I'll start and then hand on then. So
thank you.
Jill Britton, I'm the Director of Adult Social Care, and I'll go to Hannah.
Hi, Hannah Roscoe, Senior Public Health Registrar in the Public Health team, and I'll pass on to Elizabeth.
Hi, good evening. I'm Elizabeth Elliott, Public Health Consultant, and I'm going to pass over to Nicola.
Hello, I'm Nicola Ainsworth. I'm Public Health Consultant as well. I'll pass on to Amanda.
Hello there, I'm Amanda Flower, Deputy Director of Primary Care and Neighbourhood Health with Central East ICB, and I will pass on to Catherine.
Thank you so much. And if you could introduce yourself, please.
Hi, I'm Councillor Umi Ali. I'm the Portfolio Holder for Children's Services and Deputy Leader.
Thank you. Any urgent business, Mary?
None received, Chair. Thank you.
Are there any references from committees and other bodies, Mary?
None received. Thank you, Chair.
Okay, so we have, are there any items for noting?
Those are from items, sorry, Chair, from items number 7 to 12, but there will be presentations within those.
Okay.
Thank you.
Right, so the first presentation is Best Start in Life Plan, and I believe that will be Elizabeth Elliott, and you're in the room.
I'm not, I'm here. Sorry, Councillor.
Oh,
sorry,
okay.
Chair.
That's fine. Thank you, Elizabeth.
I will introduce it today, but I'm actually going to hand over to Neela, who is our Best Start in Life lead and has just joined us online as well. So thank you very much, everybody, for putting us on the agenda today. This is our BISL, our Best Start in Life, our BISL plan, which is a new approach to how we work in a partnership with across the system, but with us, public health and the children and families team, to address the health and well-being of 0 to 5-year-olds in order for them to achieve the best, the potential for them, achieve their potential, with a specific aim to improving their good levels of development at the end of reception. We've been working really hard on a strategy, and Neela's going to do a short presentation just to explain the work, and then we'll be open for questions.
Sorry, everybody. I took myself off mute. Good evening, everybody. My name is Neela Adjaman, as Elizabeth said, Public Health Manager for Children and Families. And I'm going to just give you a quick presentation around the Best Start in Life. I do refer to it as BISL, which is just what we've used to shorten it. It's quite a mouthful. Thank you. Oh. So the Best Start in Life plan, we have got a local plan now. Purpose of bringing it here to the board here is just to note that we have got that local plan, to acknowledge the work we've undertaken and the data and the governance arrangements that are in place, and also just to support the continued approach and direction of travel of the plan. The Best Start in Life was set out by National. We were given as a statutory obligation, all local authorities were to complete the BISL plan, at which we have now done. There was a little bit of delay due to just getting through the processes, but we have now got it on our Family Hub website. The primary aim of the paper is to support all children to reach a good level of development. 75% is what the government has set nationally, but they have also set different local targets based on where the local authorities sit currently. So by 2028, 75% of children to reach a good level of development. Sorry. So just for the room, just to be clear what good level developments are. Good level development is assessment that takes place, as a national assessment that takes place at the end of reception, and it ensures that children have got those real building blocks and understanding of underpinning knowledge to get them ready for learning. Once children go into year 1, they enter into the national curriculum, which changes direction of their learning, but this part of the early years framework really ensures they've got some real good skills and some knowledge they're able to learn. And we know that data shows us if children we get it right at this age for children, it gives them the building blocks for lifelong learning and achievement, not just academia, but also in their social well-being and how they show up in society as an adult. Currently, we sit at 64% all children, and we have 52.4% for our children on free school meals, children who often need more disadvantaged. So the National have set a target for us of 71% for all children and 62.7% for children eligible for free school meals. And we really will be working hard at reducing that gap around our children who face more disadvantages than others. And just here a little bit of data looking at kind of where we've been, so 2023, and where we need to get to. So we do have some work to do, but we don't start from the bottom. We've got some really strong data-driven approach. We've got some really good working relationships with Carol Wild and her team, and we're really confident that we can begin to push that. We've been doing some work with our health staff, which is looking at bringing together that understanding what happens at the mandatory check at 2 1/4, what happens there and how we track those children and ensure that we are closing those gaps and reducing the need for things to escalate or gaps to widen for those children, particularly those children who are most vulnerable. We recognise that getting our GLDs, though the primary aim, there are many things that contribute towards that, and the factors much wider than kind of what happens in education alone. You know, our homes, our safety, our jobs. If parents haven't got jobs that they're secure in and homes that are safe and comfortable and free from violence, that's going to impact the child in other ways. So the good level development, though the main measure that the government are looking at, we do recognise in order to get that, there are lots of contributing factors towards that. So we really are keen on looking at that collaborative approach, and a really exciting time that we're not just looking at education, but looking at all elements that contribute towards having the best start in life. So the core aims of the plan is looking at the good levels of development I've explained, reducing inequality, strengthening family and community support, and promoting integrated ways of working. There's a real push in the paper around parents being the first educators and empowering parents to have to be able to make those choices and to be able to show up for their families in a way that is suitable for them culturally, community-wise, and also at the earliest opportunity. What does this mean locally? This is just a real picture of what we see as the Best Start in Life plan being the umbrella, but all the contributing factors. So that's Flying Start, our under fives offer. Luton Family Hubs are still very much around. It's going to be our network of bringing people together. We have our Family First, our early help. We've got health and we've got early education. So we look at all of those people contributing towards that. It's not one department's responsibility. And then we've got the home, we've got early year settings for those children who are involved in it as well. So we just really want to make sure that it's a collaborative piece of people working together and not just one profession's responsibility. Though the GLD is what we're measured by, we recognise it takes lots of people to get there. Part of our plan, which you can see on our website, we've got 6 objectives. We're looking at all the different areas. I won't read them to you, but they're just an overview. They're in the plan was attached to the paper. So again, looking at what we can do, and it does cover cross-sector. It's a really holistic objective, not just one area, starting from pregnancy right through to sort of supporting families. The governance structure has changed. So historically we had Flying Start, our under 5 offer, had their own strategic board, and Family Hub had their own strategic board. We've amalgamated those now to become the Best Start in Life strategic board, because essentially that's what we've done now. We've become one, and then we'll be reporting to Health and Wellbeing board, and we really do align very strongly with the child friendly Luton board. So that's where we'll be taking it to, and with a really strong joint responsibility with children and families as well. We're working very closely with Family First and with Carol Wild's team to ensure we've got that. Another element of what's come in is the SEND area. We know the SEND reform is on the horizon, and Tracy and her team will be working very closely with us with that as well. Our delivery plan, again, we need to be able to produce our delivery plans. We're looking at, we've got really clear reporting lines. We have working groups that are working together that will be monitored and reviewed quarterly, and then be fed up into our strategic board on a regular basis with that oversight. So we have got Michelle Bailey, our public health principal, and Carol Wild, who are taking that strategic lead on that currently. There is a requirement to have a Best Start in Life lead, which we have gone out to recruit for, and we are hoping to interview in the next couple of weeks. And there are some other roles around special educational needs called a BIZIP, which is Best Start in Life inclusion practitioner. We also do need to have those in as well, and those are mandatory roles that do need to take that to take place. So we are in the process of recruitment with those at the moment, and they will help the delivery. Any questions?
Are there any questions from the floor? Any comments even? Umi, go ahead.
Thank you. And I also listened to his thought in Children's Scrutiny the other day as well. I would like to see a little bit more information, just separate. This report is great, thank you. And it's really good to see the partnership and working together as a system with the Best Start overarching, and then linking in families first and education and all of that. I think it's brilliant. But in terms of uptake and support, some demographic data, particularly for families that may have English as a second language, the mostly disadvantaged families, that sort of stuff. Because some of the feedback we get from the public is that they don't know that these are here, that they exist, or that they're difficult to access if you don't live very centrally. Just a comment. Thank you.
Thank you, Councillor. And just to respond to that, I really do take that point, and we are working really hard at that. We are looking at making sure we're placing those areas that people need us the most, and there is a real push on working with our most disadvantaged families. So do watch this space. There will be more coming.
Thank you. Yeah, that's very much the key to reaching 2040 and reducing inequality for us. So thank you, everybody. We're going to move on to item 9, which is neighbourhood health. No, it's not. Hang on. Number 8, sorry. Bedfordshire Fire and Rescue Services Partnerships and Outreach with Luton's Communities by Bev Davis.
This is an update based on a presentation I gave about this time last year. I appreciate it's a hot evening, so I have not brought slides. if you were here last year, you'll remember I introduced our Home Fire Safety Visit programme, which is our main prevention intervention across Bedfordshire. And I'd like to just update briefly on developments delivered and in progress, particularly developments following the fire fatality in Luton in June last year that have been significant. Just a brief overview, the replacement report details all of our impact, but there are, I think, 3 key points to note. Our number of visits has been more or less the same. We visit over 2,000 homes in Luton. We visited 2,058 last year. Our average total risk score, when we visit a home, we accumulate a fire risk score as we progress through the visit. That has actually increased from 19 to 21. So we are seeing more homes that are more at risk in Luton. And there's been a general increase in the percentage of risk groups we've visited across all groups. So we are really pleased at the amount of partner engagement we have in the locality. Full details are detailed in section 5 of the report. Partner referrals indeed have increased 2%, and our partner referrals have sustained that average total risk score of 21. We've done a significant piece of work with adult social care and wider Luton Council teams, particularly the social justice team and the fairness task force, and are delighted at being able to contribute to the Health Equity Town Partnership and the wider public health interventions across Luton. And note that our Safe at Home scheme that we run in association with Flying Start and the Early Years Alliance, which I think is now in its 15th year, was awarded Partnership of the Year at the Asian Fire Service Awards in late last year. I can't. October, November time, which is a real recognition of the impact with families where children are 0 to 5, particularly in regard to the best start in life. Our real concern, though, is older people and risk in the home. And I would like to talk a little bit to our adults at risk management framework. This is a significant development of our practice, triggered following the fire fatality in Luton in June 25 and reinforced by the fatal fire in Houghton Regis. And it builds on lessons from earlier incidents in Dunstable and particularly the Dewsbury Road incident in June 23. So it's a structured, enhanced risk evaluation process for people who we visit on a home fire safety visit or who come to us through safeguarding and other pathways where the person in question cannot safely evacuate in case of a fire. For example, they may have reduced mobility and there's also an ignition factor present. So they may smoke, they may have unsafe behaviours around smoking, there may be hoarding and unsafe heating in the home. So it enables us to assess risks more deeply. And you've got an example risk matrix and case study in the report that are quite compelling and I would really recommend reading because we are supporting people, and there's 48 open cases in Luton out of just over 100. So I think that's 48% of our open cases are in Luton at the moment. So we are working with the professionals around that individual to reduce risk to as low as is reasonably practicable. So these are people where even a minor fire could lead to a fatal outcome. And I think it's notable to mention here that whilst 6% of our fires in Bedfordshire are caused by smoking, 63% of those smoking related fires are fatal fires, and 80% of those fatalities are people over the age of 65 with reduced mobility and other intersecting risks. So this is our response to high ignition behaviours, environmental hazards, and person factors such as immobility, dementia, frailty, and that limited capacity to recognise danger or self-rescue. So there's more details on our ARM framework in there, but it means we are working very closely with social workers, with health, with hospital discharge teams as well. We have done a training piece at the L&D and are looking forward to doing the same at Bedford. So, interestingly, the case study in my report has had a very positive outcome. The individual is now in full-time residential care and we've closed our involvement. So we are really reassured at the engagement we have had through this process. We are working very closely with Central Bedfordshire social work, adult social care team as well, following the fatal fire in Houghton Regis, and learning from their approach to what the coroner's report asked them to consider. I hope we'll be able to bring to Luton, because we've already opened that up. They're putting a very bespoke fire risk assessment protocol in place, and we will feed back on developments there and keep the Health and Wellbeing Board updated. So a very brief overview of some significant impact in the last year.
Thank you, Bev. So I'll open the floor to questions. Me.
Hello, thank you, Bev. I really enjoyed your report last year, and I was really excited to see that come again. Not excited, but I just think it's nice to see that the wider work that the fire service does, people don't realise. And when you look through this, you play a key role in safeguarding across the whole system. So it's really, really useful to see and really lovely to read the progress that you're making and the partnership working, I think, is a really good example of how we should work as a system. I wanted to pick up one thing that I don't know if it is that I've skimmed past in the report, but around housing and safety around housing in houses of multiple occupation. So it's not a surprise to anyone to know that we have so many HMOs across Luton that are unsafe, and particularly in more specific central wards where we don't know how many there are because there's no need for them to be licensed. And the council are now putting forward a licensing scheme, additional selective licensing, which means it's easier for us to understand. And a key element of that is those houses being up to a standard. And I have a number of residents that come to me and say, surely this house is a fire safety risk, even if it's not illegal for them to have 7 beds in a 3-bed home. Is it a fire safety risk? So it would be useful to understand the work that you do around that and how you can work closer with our housing team that are working on this new selective licensing and additional licensing scheme as a partnership going forward to help tackle that issue.
It is a really important concern for us as well as for the HMO team at the council. And I think the piece of enforcement work we recently did in Bury Park is a really good example of that. Colleagues from private sector housing, from our protection team, and there was another team involved, I think, from the council as well. We're out and about in Bury Park for, I think it was 2 days in the end, looking at all the properties that were a concern, serving enforcement, offering support, doing home fire safety visits, making referrals for those. I can come back to you with further details about our work in terms of the HMO piece. It doesn't sit within prevention, it sits across prevention and protection. But we have, I know, a partnership agreement with all of the HMO teams, if you like, in our local authorities, and can come back to you with some data about the work we've done there.
Dheeraj.
Thanks, Bev. Hi. And thanks again for the report this year as well. Just, I think we may have had a very brief conversation the last time as well about how we enhance our opportunities for working together.
Yeah.
Particularly for vulnerable families with children present.
Yeah.
And I suspect it's in your annual statement of assurance where you cover off the statutory responsibilities under working together.
Yeah.
And I wonder if we might see a little bit more about that coming to life in a future report.
Okay. Yeah. I think just to give an immediate response to that point, our work with Safe at Home, I think, is a really outstanding example of how we do that as both local authority and fire and rescue service. And it's interesting that other areas have come to us asking for details of how that works. But certainly I'll make sure to feed back on that. Thank you.
Thank you, Kate.
Thanks, Bev. And I think I was just a couple of points from me really. One is really good to see that relationship with adult social care is strong and strengthening. And I think, yeah, absolutely, that's really positive to see. And the work around hoarding, we know, is a big fire risk. I think in terms of your ask about how to embed some of your prevention activity into multidisciplinary frailty pathways and dementia pathways, etc., I think there's a real opportunity. We're developing the neighbourhood health team,
absolutely,
which will have that focus on frailty. And so maybe there's an opportunity for us to really work with you about how we can embed that within the workings around those new MDTs that we're setting up. I think I've also got responsibility for council housing. So whilst I don't have private sector housing, I do have council housing.
Right.
And I think that there's an opportunity for us to have a conversation around council housing in particular. And then my last point was around we also manage the Traveller site at Stopsley.
Yeah.
And obviously I'm aware that, you know, I can't remember whether it was last year or the year before, you had the really big fire at Hertfordshire.
That Redbourne, yeah.
Yeah. And so there's also making sure that we're connected in terms of managing that site as well.
Yeah, let me talk to that, because the Community Safety Officer for Vulnerability is part of my team. We have done an engagement piece with a local PCN out at Stopsley, not this year, but last year. I think it was April, we ran a station experience day for young people, partly from that site as well, at Luton Fire Station. And the CSO for Vulnerability, one of his objectives for the year ahead is to develop a sustainable pathway for engagement up at that site. So we'll reach out, Kate, and let you know. Thank you.
Thank you, Bev. Sorry, go ahead. Yep.
Yes, thank you. Bev, I know our team's already connected around the falls pathway, very much embedded, but there's further work, I think, again, on your ask in section 10 about working with us and getting it embedded in the frailty pathways, into the dementia pathways. And I just suggest we have a conversation outside of here with our service director about how we can get closer alignment of all teams with yourselves.
I think the point about dementia and about frailty with the work that the ICB are doing with neighbourhoods, absolutely a key moment. So thank you. Yeah, perfect.
Yeah, thank you for that, Bev. And I was going to say similar. So we do the point of diagnosis. So people, you know, it's actually, there's an opportunity, I think, to think about when people's memories are starting to slip and their reasons for coming to memory assessment services. So happy to catch up outside here around that.
I think a piece of work we're doing with TIBS dementia in beds and central beds is something we can replicate in Luton. So perfect, Michelle. Thank you.
Are there any other comments or questions? No, excellent. Thank you. That was quite generative as well, which is really useful for us. Yeah, that was to note. So thank you for presenting. So we're going to move on to item 9, which is neighbourhood health update, and that's Amanda Flower, who is online, I believe, or in person? Online.
Yes, I am. I'm online. Thank you. Thank you, Chair. So I'll give members of the board a summary of the paper, and then in the usual way, very happy to take questions. So at its previous meeting on the 8th of April, the Health and Wellbeing Board received a paper which really reported on neighbourhood health planning and set out the national policy and context. The paper today builds on that discussion and starts to demonstrate how we are creating the conditions that is required in 26-27 as we move towards making neighbourhood health teams operational in practice. So neighbourhood health is a key national and system priority, and it's set out in the earlier published neighbourhood health framework and in Central East ICB's Our Way strategy, which is a separate paper to this board. The intended approach positions neighbourhoods as the core unit of delivery for the populations, but that will improve population health, support reducing health inequalities, and ensure that we shift care closer to home for residents. So significant progress has been made in developing the Central East approach to neighbourhood health teams and the Luton approach. As I've already said, the focus in this year is how we create the conditions to allow neighbourhood health teams to flourish, so that we can deliver at scale from April 2027 onwards. There is currently no single model for neighbourhoods, and therefore the work that we are doing as an ICB and with all our system partners is to create those conditions that will systematically identify, strengthen and learn from existing services and pilots and bring good practice to inform a more consistent and evidence-based approach to neighbourhood health for our population. So in 26-27, our approach with system partners is to baseline our system and develop that understanding of asset mapping, neighbourhood health team and frailty services across to provide that clear view of current provision, variation and those opportunities for improvement that we want to deliver through that neighbourhood health model and those neighbourhood health teams. We'll develop a consistent and clinical delivery model with partners. We will use early adopter mobilisation and testing so we know what works well, and we're doing some of that in Luton through the Luton Place Board and through the Luton Strategic Neighbourhood Group. We will improve data and population health performance and develop that infrastructure, rolling out tools such as Delphi, which will give risk stratification to each of those neighbourhoods. We will focus on the progression of system-wide data sharing arrangements so that those neighbourhood teams can benefit from interoperability and shared information that will allow residents to access care closer to home, to tell their story once and to improve their experience and outcomes of care. We're looking at how we align services, contracts and investment, and all of this will prepare us for that future commissioning from April 2027 for a neighbourhood health and neighbourhood health teams. So all of these actions represent that coordinated approach to create those conditions for neighbourhood health. So our plans remain in draft and dynamic form, and we are continuing to engage with all Luton partners. Many of those are members of this board this evening, to ensure that that approach that we take is tested and works for our population. We've been undertaking a range of system leadership and alignment and engagement activities since we reported to you back in April, and our BLMK Neighbourhood Delivery Committee, which is a subcommittee of the ICB board, has received further updates on our progress in our places to deliver neighbourhood health. We've undertaken a number of key planning submissions, which really demonstrates our approach in Central East ICB and in Luton, and that's the Better Care Fund plan, the Primary Care Action Plan, Primary Care absolutely central to how we deliver neighbourhoods, how we will deliver better same-day access to general practice, and our intentions around neighbourhood health centres. So in Luton, as I've already mentioned, we have a very active Luton Strategic Neighbourhood Group who is working through a series of task and finish groups where all partners are present to design how we roll out neighbourhood health and neighbourhood teams in Luton around the 4 agreed geographical neighbourhoods of North West, North East, Central and South. The task groups will really drive forward with system partners to help us design that consistent model that is designed to support population needs and resident needs. So as described, we are moving from design into operational delivery, testing what works, drawing out best practice and building on already successful work in Luton. We will continue this work as we finalise the Central East activities around creating the conditions through those priority task groups that I've described with Luton partners and through the local governance arrangements that we have in place. I will stop there and I'll take any questions.
Thank you for that update, Amanda. Are there any questions or comments from the floor? Thank you. We're going to move on to the next item, which is yourself again, Amanda. And Amanda's from the ICB. Thank you. I should say what it is, shouldn't I? Yeah. Okay, so it's item 10 and it's Our Way Strategy to Delivery, the Central East 5-year Strategic Commissioning Plan. Amanda, it's over to you.
Thank you, Chair. So once again, I will summarise the content of the paper. Previously, at its meeting on the 8th of April, the Health and Wellbeing Board received a paper that was introducing Central East ICB's Our Way Strategy to Delivery. As the new organisation, Central East ICB, came into being from the 1st of April, it launched this strategy that sets out how the ICB will operate with system partners delivering for its population, its 3.5 population. The approach in the Central East strategy emphasises learning from variation using data, population health management, drawing on lived experience and multidisciplinary input to understand what delivers the best outcomes, and particularly for those high need groups, such as those people living with frailty, which is the focus for neighbourhood health teams in this first year. As our work develops, the ICB will continue to work closely with partners and Luton Borough Council to apply this QI approach to local delivery. Our intention is to codify effective models and support consistent rollout at scale and in the future through formal commissioning of neighbourhood models. The approach from the Our Way strategy is rapidly beginning to be applied in practice across the system. There are multiple existing pilots and models, including in Luton, which provide a strong base for our learning. So the Our Way strategy sets out 6 structured stages, which are described as A to F. That is to identify and improve, which demonstrates how real problems can be improved in real settings. A plan, do, study, act approach to delivering the product, how we make business investment decisions, how we commission and mobilise, how we move from those safe, controlled, tested models to a safe spread for our population, and how we ensure that services continue to deliver value for our residents and are adapted, and how we make very intentional decisions to adapt, to redesign, or to stop initiatives or models that are not working. This ensures that our improvement approach is not undertaken in isolation, but is linked to commissioning, investment and system-wide delivery. It enables the ICB to move from multiple local developed approaches to a more consistent evidence-based sets of models. So the Our Way strategy describes priority programmes as prevention and screening for cancer, self-care for MSK, utilising risk management in cardiology, and that has a focus initially on heart failure, care coordination for advanced illness, and acute care pathways for residents with mental health. The strategy goes on further to describe provider collaborative priorities, which include dermatology, diabetes, neurodiversity, and the paper that I've already spoken to, which is neighbourhood health teams and the delivery of those in our places. Thank you. Happy to take any questions.
Thank you, Amanda. Are there any questions? Any comments? Thank you, Amanda, for speaking to both of those reports. There were 5 recommendations in each. They're listed in the document pack. Do we accept those recommendations and note those recommendations as a group? Thank you. Okay, so we're going to move on to number 11, which is the Domestic Abuse Strategic Plan Update, and that's Nicola Ainsworth, and you're online. Nicola.
Thank you, Chair. Thank you. So the paper you have in front of you provides the board with an update on how we're progressing with the new system-wide domestic abuse strategic plan. The board has seen the strategic plan before, and it is included in the pack. But just to remind you, the 5 key priorities of that strategic plan are to prevent abuse before it starts, to intervene early to stop escalation, to provide safe housing and support, stop perpetrators from reoffending, and ensure clear pathways to safety. So each priority has a number of key objectives within it, and the detailed delivery plan is included in the pack. And on page 53 of the pack, you'll see we have a RAG rated chart, which shows how we're progressing at the 6-month mark following the approval of the strategic plan back in January. So hopefully you'll agree that we're doing reasonably well in meeting the objectives so far. The priority work streams have assigned co-leads from both the statutory and voluntary sector, and more actions will be added to the delivery plan as these groups develop and carry on meeting. So very happy to come back and give further updates as we progress. But one final point that's not included in the paper is that we're working on a pan-beds basis to develop a data dashboard whereby we'll be actually able to measure impact of the strategy. It'll include indicators such as repeat rates for domestic abuse crime, repeat rates for cases that are seen at MARAC, and in addition, things like indicators such as the school survey, where young people's views on unhealthy relationships behaviours are collected. So all of those sorts of things and many more, because each priority will need to have at least one key outcome indicator. So happy for Jenny and I to take any questions. Thank you.
Thank you, Nicola. Are there any questions or comments from the floor? So domestic violence is at a high level, and that's the reported levels of domestic violence. And certainly as a council, for us, one of our priorities is safety. And we often think of safety as being outside of the home, but actually safety within the home should certainly be a focus for us. And we should always bring attention back to the fact that many women and men don't feel safe within their homes, and children are affected by that. And I think that when we think about safety as one of our priority areas, we have to include safety within the home. So thank you so much for the report. We will continue to support everything that our partners do. And I think it's incumbent on us to try to think of creative and imaginative ways to reach to those who we're not really supporting in the best and most effective way at this time. But we've had those conversations before, and I think that there are improvements in terms of the people who are taking up our services. But we've got to really look at why and look at the roots as to why this is happening. And that's a responsibility for us as a local authority, and we continue to keep it as one of our top priorities. So thank you so much for speaking to that report, Nicola. Thank you.
Thank you.
Jeez.
Thank you. Thanks, Nicola. And I remember when this report was going back and forth, every meeting I was ever in, policy, Labour, all the meetings. And I remember at the time all the comments that we made, and I think it's a really, really good plan. The 5 priorities are really good. And it's good to get a little bit of an update on the current progress on what we were doing to deliver our objectives. But it's not fully clear how much of that progress started before the plan was put in place and after the plan was put in place. And then just one specific question around supporting safe housing. And at the time, I think I was talking about some of the joint work that we're doing with the OPCC and the council around safe housing, and some of the housing first and other approach that there is available around safe housing, the perpetrator housing. It's the heat confusing me. So housing for perpetrators, so that women aren't taken away from their homes and their support systems and their experience in domestic abuse. And I guess I'd just like to see a bit more around what we are doing in that priority 3 area. You probably are doing quite a lot. It's just in the report, it didn't say much under the current progress there. Thank you.
Thanks, Councillor. Yes, we'll make sure that for the next update, and we can send you a written update if you'd like, about what's being done, more that's being done in that space. In particular, as you mentioned, housing for perpetrators, so that families, the ones who are affected, don't have to leave their homes. Can't give it to you at the moment unless, Jenny, you'd like to come in with anything.
Hi, everybody. No, we don't have an update at the moment around this is the Mary Seacole project, I think, that you're referring to, around it's
Not
a small.
specifically, I think I just
okay.
given an example of that, but just stuff that we're doing around housing for domestic violence.
Absolutely.
In particular.
To be absolutely open with you, we've struggled a little bit to find a co-lead in our housing team. So some work has been carried across. As you know, we work closely with Women's Aid, one of our service providers, to provide refuge accommodation, which is one of our statutory duties, safe accommodation for victims and their children. We have appointed a co-lead from our voluntary and community service, and that's going to be a lady who works at Luton Hall Women's Centre at the moment. We're still awaiting our statutory partner, co-lead, to be volunteered / nominated / agreed. But yes, so the work is kind of ongoing, but the very much the plan is being kind of, we want the priority leads to collate, you know, they are the subject matter experts. We want them to collate the information and to have their fingers in all those project pies, as you know, such as the pie that you mentioned, Councillor Ali, around housing for perpetrators, and as well as safe accommodation and move on accommodation, and kind of the single homelessness pathway, and all those kind of other kind of housing activities where domestic abuse is such a major element of that. You'll be aware the council is undergoing the Domestic Abuse Housing Association accreditation at the moment as well. So there's lots of work ongoing, but as Nicola has indicated, we don't have all of that information at our fingertips, but we know that our subject matter experts do.
Thank you. And hopefully we can find that lead for you in the housing team.
That would be great. Thank you.
Was there anybody else? Okay, thank you. Thank you for that report. And I recommend that this board recognises the progress made and provides any relevant support going forward, as we should. Thank you. So the next item is item 12, Mount Vernon Cancer Centre update on the consultation to relocate. And that's Hannah Roscoe, and you're on, hang on. Yeah. So is it Kelly? Oh no, so sorry, my apologies. Hannah Roscoe is online, standing in for Kelly. Thank you.
Yes, that's right. Thank you, Chair. So yes, the purpose of this item is to give a progress report on the Mount Vernon Cancer Centre relocation proposal, and building on the update that was given at the last Health and Wellbeing Board. And this is a process that's being led by NHS England, but to which we're contributing. Very briefly, to give some background, I'm sure people are aware, Mount Vernon is a specialised cancer centre in Northwood, Middlesex, that serves Luton, but also a number of other areas. And there's been an awareness for some time that the cancer centre can't continue in its current location. It's located in what was formerly a TB sanatorium, and the age of the building and the fact that it's not co-located with acute medical and surgical facilities means that they're already having to turn away some of the more complex cancer cases. So it's been recognised for some time that there's going to need to be a move. There was a consultation on the proposal to move from January to March this year, which consulted on 3 options, all of which involve a relocation to Watford Hospital, which has been identified really as the only site that meets all the requirements for the centre. But the 3 options were a relocation to Watford, with all the services being provided on that site, and then 2 further options where there's networked satellite radiotherapy provision. So option B was for that to be at Lister Hospital, and option C was for that to be at Luton and Dunstable Hospital. As agreed at the last Health and Wellbeing Board, we submitted a response as a council going for option C, which would mean that at least some of the services were at Luton and Dunstable Hospital, which would benefit our residents. The findings of the consultation have now been made available. So overall, there was just about support for the relocation. So 48% of respondents to the consultation were supportive, compared to 42% who were not, and 10% who weren't sure. So NHS England, on the basis of that, are going to move ahead with this relocation proposal, particularly in light of the fact of the pressing clinical need. In terms of the network radiotherapy options, 17% of respondents to the consultation went for no network radiotherapy, and then there was 29% each in favour of Lister and Luton and Dunstable, so it was quite balanced. Other concerns that were raised were largely around travel to the new location and also the loss of the green space and the nice atmosphere that they have at Mount Vernon at the moment and how that will be affected in the new Watford location. So the next stage of this work, NHS England are moving to a detailed decision-making business case phase where they're going to do detailed costings and design of the new location, and also the decision will be made around whether there will be networked radiotherapy and where. There's going to be an assurance checkpoint in early autumn where those decisions will be made public. And what we've asked for is the Joint Health Overview Scrutiny Committee, which Councillor Underwood has been a part of, that the life of that is extended so that they can scrutinise the next phase of the work. So we're just waiting to hear on the outcome of that. So that's the update, and happy to take any questions.
Any questions or comments from the floor? No. Oh, me, go ahead.
So, I'm really sorry. So I'm not clear. So are we say of A, B and C, it's just because it's quite a long report and it doesn't make it clear at the start. So of A, B and C, because the consultations just ended at the start of June, are you saying that you're still reviewing the responses, but that you're going to go ahead with, sorry, I just wanted to clarify what is the option that's going ahead, or are you going ahead with Watford while still exploring?
Yeah, happy to answer that. It is a bit confusing because the main proposal really is about the move to Watford, and options A, B and C are about a kind of sub-proposal about whether or not there'll be networked radiotherapy. So the overall proposal about the move to Watford is going ahead, and then whether it's which of the networked radiotherapy options they go for has not yet been decided. So we don't know whether it's A, B or C at the moment. Does that make more sense?
Yeah, thank you. That makes much more sense. When will we know if it's going to be A, B or C? Because A is just all in Watford, isn't it? And then B is Lister and then C is Luton. And how long will it take for us to know that? How can we assure residents that they'll be able to access services without having to go to Hertfordshire if it's A or B?
So they're going to make the kind of the full details of the proposal available in September. And I agree with you in terms of assuring our residents. We argued very, very strongly in our consultation response to have network radiotherapy at Luton and Dunstable. But that's why we've asked for Councillor Underwood's role and the Joint Health and Overview and Scrutiny Committee to continue so that we can continue to scrutinise and challenge if needed, because, yeah, at the moment, we don't know which of those options is going to be selected.
Sorry, one more, and we don't know when either we'll get the decision. Is that?
So I think available in September is when they're going to have a phase which they're calling. They're issuing it for public challenge. Yeah.
Thank you.
Thank you for the question and for the response. Any other comments, questions? No? Okay. Oh, sorry, Richard, go ahead.
Yes, thank you, Chair. If I can just chip in what Hannah was saying about the next, excuse me, about the next stage, about the consultation in the next stage. The present JHOSC was only legally constituted for this consultation period, so that's been wound up. So we have to go through the whole process again of reconstituting a new committee to scrutinise the business case and all the rest of the decision making that's going to go on in the next phase. And I think I believe that's a decision that has to be made by full council whether we take part in that process, which personally I believe we should. There is, as Hannah was saying, there's a lot of issues still to be thrashed out, particularly around travel arrangements for people travelling to the new centres. I think this is particularly pertinent for people from Luton who might not have access to cars, who are dependent on public transport, and we are the majority of our fellow of our fellow members on that committee are from how should I say wealthier parts of the area who tend to be car drivers. I think it's important that we get of the views of our residents across in the next part of the process. And also, so the clinical case is overwhelming to move the centre to from Mount Vernon to Watford. We need to take that 42% who said they don't want to move, who said they don't want the centre to move. We need to take those people with us on that process, and I think that's going to be a very important part of the next phase of consultation.
I think you raised some really important challenge there, Councillor Underwood. So do you want to come back on that, Hannah?
Yeah, I think absolutely in agreement with Councillor Underwood. As I said, this process is being led by NHS England, so I think our role as Luton Council is really advocating for our residents within the overall process, and I think that reinstating the JHOSC is probably the best way to do that.
Thank you. Oh, right, sorry. Yeah.
I mean, another good argument is the uptake of cancer treatment from people in Luton is very low due to deprivation, due to car travel, and that should be something that's considered. One thing that wasn't considered, which I was a bit surprised in the consultation, and maybe will be now, is looking at areas where it could be, because, you know, Luton and Dunstable Hospital to me seems an ideal location and stuff, but that wasn't part of the consultation.
Again, Health Watch, you know, from your perspective, you make some really good points, and I think that's another, a challenge that we should really take note of. Again, Hannah, do you want to come back on that one?
Yeah, my understanding is that there was an initial options appraisal looking at the requirements of the new site in terms of co-location with particular facilities like an A&E, and other considerations around things like travel, parking, even things like electricity substations, because as a cancer centre it will have a high energy use. And I believe the outcome of that was that Watford General is the only location that is suitable for the main site, but then what's going to hopefully balance it is having some satellite services at other places. So I think that's what we can continue to advocate for.
Thank you. Oh, okay, go ahead.
Forgive me interrupting, Chair. Sorry. Apologies. Kathy, we can't hear you. Do you want to try another microphone? We can't hear anything. No, I don't think it's working, that one.
Sorry.
That's it. We can hear you. Thank you.
Better. Sorry, apologies. I won't recap all of that, but just to say that our Luton clinicians who are part of the Mount Vernon team were strongly in favour of the Watford proposal as the only viable proposal for the full delivery of everything required. Our teams will support with the
design and the information that's required to form the decision-making business case as to the viability of each of the spoke options or a no spoke option for radiotherapy. And again, we understand and will reflect council members' concerns and the wider Health and Wellbeing Board's strong advocacy for our residents of Luton in terms of our access to travel and so on.
Thank you. So important for us when we reflect again on health inequalities. But we'll close there. I don't think there are any more comments or questions. The recommendation is that the Health and Wellbeing Board note the consultation draft findings and next steps in the consultation process. Thank you. So we're going to move on to discussion items now, and the first one is item 13, and that's Adult Social Care Quality Commission CQC Inspection Outcome, and that's with Jill Britton, who's online. And there was an amended covering report, which is on page 87. It was a small amendment, but if I hand over to you, Jill.
Sorry, Chair, it's Catherine Doker. I'll be presenting today. Thank you.
Okay, all right. Sorry, apologies.
So good evening, everyone. I'm here to present the outcome of the CQC inspection and adult social care plans to address areas of improvement. So for those of you who are not familiar with the CQC assessment process, there is very structured framework and they look at evidence across a number of categories and based on the findings that they from the evidence that we present, they then give us a scoring. Now, the scoring framework is from 1 to 4, 1 showing significant shortfalls with 4 showing exceptional standards. And I'm absolutely delighted to share with you that Luton achieved a good score and we achieved a really good rating and we achieved a score of 67%. And out of the 9 categories, 6 showed good evidence of standard delivery. So just to summarise for you all, our key strengths were there was evidence of a really good preventative and community-based support offer, which was really proactive in providing short-term interventions, which empowers individuals to achieve a greater level of independence and reduces the need for ongoing care. They really recognised our good reablement offer, our local coordination offer, and our prevention enablement work, which looks at sort of connecting people, you know, offering sort of training programs and really works on that strength-based approach to build people's independence. And that's crucial in enabling people to reduce the need for ongoing care. Secondly, they really acknowledge our care planning and assessments process. They, you know, could see good evidence of a person-centred and strength-based approach, and it showed that, you know, our practitioners really honoured people's rights and choices, and we also, you know, they focused on our whole family approach, not that we only support on the person that required the assessment or care and support, but also how we focused on carers and how we worked with them to make sure that they were, you know, could continue in their caring responsibility. They also acknowledge our partnership and community collaboration, and they could see how we really are starting to work closely with partners and communities to look at our strategic priorities and making sure they're aligned, and that we are, you know, focusing on co-produced initiatives to sort of look at long-term conditions and how do we address health inequalities across the town, particularly for those populations that are undeserved. They were really pleased about our safeguarding protocols, how robust they are, and ensuring that our safeguarding inquiries are dealt with timely and making sure the voice of the person is always at the centre of any safeguarding matter. And they recognise that we've got a really strong safeguarding adults board that works in collaboration with a number of partners to make sure that our safeguarding approach within the community is very collaborative and coordinated. And finally, they recognised our leadership and they acknowledged that we've got really clear and effective governance in situ. You know, it's making sure that we are accountable and that we're satisfied as a council that we are delivering our Care Act duties and that we provided reassurance and visibility while undertaking these duties. And additionally, they were really pleased about the staff culture and how the service is really focusing on sort of good support, really good training program, inclusivity, and enabling the people, the practitioners, to sort of move up in their career. In fact, one of the inspectors mentioned, you know, during the inspection, they would love to come and work in Luton. So we were delighted to hear that. Moving on then, of course, like any inspection, there are areas of improvement, but I think it's notable to say that we're very self-aware. A lot of the areas of improvements, there was already plans in train to work on those areas. And also, it's important to sort of reiterate that none of those areas of improvements were noted to be of serious concerns. So where they identified that we needed to do some work it was about addressing our OT weights and looking at our carers assessment and financial assessments. And since CQC, we've done a lot of work since November. So our OT waiting lists have decreased by 53%. And equally, our financial assessments has reduced by 35%. But we're continuing ongoing work in these areas to make sure that we're maintaining and to continue working towards improvements. Secondly, they noted that our website wasn't always easily accessible, wasn't always easy to navigate either. However, we've had a whole website redesign, and this has meant that, you know, we've refreshed all of our pages. It's much more easy to navigate and it's accessible. It meets those accessibility information standards, and we've also got a really good translation function that will help us overcome sort of language barriers. Feedback from service users was largely positive. However, there was some evidence that our support models could be much more flexible and supporting people to meet their needs. And there are plans in place to address this. We will look at our market position statement and we will refresh this, and we'll develop a strategy to create a marketplace that better meets the population needs of the people of Luton. And then there was evidence of improvements to support people that are transitioning and managing unexpected changes related to our carers, and making sure that every single carer has a contingency plan they can apply if there's changes in their ability to fulfill their caring responsibility. And with transitions, work is already in train about working with people at a much earlier age to making sure that we can address any provision gaps and plan resources effectively. So, as I mentioned, there are a number of as noted in the report, there are a number of projects that are overseen by our Strengthening Adult Social Care Programme Board, and all of these projects are focused on our journey of improvement. I will touch through the main of them. So we've done lots of work with our targeting operating model. We're really embedding this now, and we've done the website relaunch, and we are just looking at digital redesign, and we are still monitoring our OT waiting list. So we're well underway in looking at our target operating model. Integrated neighbourhoods, I won't labour the point for this, but we are making progress. Amanda Flower touched on that earlier, and we're very heavily involved in Luton strategic planning to really sort of make sure that we can get ready operationally to deliver an integrated model. In terms of our strategic plans and collaborative commissioning, we will be working on developing a dementia strategy in co-production with people that use services as well as other stakeholders. And we are currently in the process of looking at recommissioning a new hospital discharge process, which will really support people to regain independence with a timely hospital discharge. And we're also looking at refreshing our older persons residential and nursing support to increase meeting the needs of an ageing population with complex needs. And then we have got a project about social work and practice, and that's really about refreshing our adult social care strategy in co-design with people that use the service and other stakeholders. But it's really about bringing staff on that journey. So as we're making all these changes and improvements, it's about how do we support staff to be upskilled and to really change practice to better serve the people of Luton. And then just some bits of innovation. We're working on tech-enabled care. We will be working with a third-party supplier to develop a really robust business plan to make sure that we are actually, making the best of tech-enabled care to enhance to enhance people's lives and to help people maintain and to maintain their level of independence. And then just finally to say that we are working with mental health colleagues as ELF deliver that delegated responsibility, and we are working on a clear action plan to improve the delivery of that service with ongoing performance monitoring and making sure this is a truly integrated part of the work with other areas of the council, such as housing. So thank you, Chair. I'll take any questions.
We are proud of the work that's been undertaken, the positive outcomes and the fact that you're working so hard to continue on that improvement journey. So, you know, thank you, Catherine, for making that presentation, and thank the team on our behalf for, you know, working so hard to get to where we are. And it's nice that it's been recognised as well during this inspection. That's excellent. So we are going to note this report and the areas of good practice and key strengths highlighted throughout the inspection process, and we are going to note an improvement plan to address the areas of improvement and set out that have been set out in the report. Thank you.
Thank you, Chair, much appreciated.
So we're going to move on to item 14, which is ongoing engagement to consult on the revision of the health and wellbeing strategy, and I believe that's Elizabeth Elliott online.
Thank you, Chair. Yes, and I'm standing in for Kelly today and presenting this report. So for the group, this paper has come before, I think, much earlier in its development. So this is just really to provide an update on progress, but also to invite you to make your consultation. And I will show you, and there is within your packs a form where you can submit any consultation. You can put your name on that, and if you would like to be if you would like your comments to be forwarded back to you, we can absolutely arrange for that to happen, but it's also a way if you want to do that anonymously as well. So we want to ensure that everyone has the opportunity to consult and be engaged on part of this process. However, we have already done a lot of consultation. This is not the start of that process. This is coming towards the end now of the process of consultation. So this is the Health and Wellbeing Board, a Health and Wellbeing Strategy, or the Population Wellbeing Strategy, as it's previously been known in Luton. And this is an update on the previous one. So this is not about we're not starting anything from scratch. This is absolutely building on all the work from the previous strategies, but also picking up on all the work that's been presented today, the number of pieces of work from public health, but also the wider public health and the whole system that works to address health and wellbeing across the whole of Luton. And this work is already ongoing. So this is our really strategic direction that we're going to continue, that we are setting, and that our services will continue to meet and work towards going forward. So we are asking you to contribute to the consultation. The documentation and the presentation included in the pack includes information on the draft that has been people have been asked to consult on, which is very much a draft, and we're well aware that there are still a number of KPIs and pieces of work that do need to be worked up, and we will take some of those and build them up into more detail. But as well as that, like I say, this is you know, that the whole piece has been consulted on, and we have gone really wide. We've consulted with a wide number of the public. We've gone to various community groups. We've gone to through Health Watch and through other organisations, and we're engaging with the public, but also with stakeholders and services as well. So the report shows the consultation that we've done and the feedback that we've had. The draft strategy is iterative, so as we build and as we receive consultation, we are developing it. So what you're seeing now is the draft as it is, but we are absolutely building on it as more consultation comes in. However, we do have a focus, and we do have a key, and our key is to really improve and deliver better health and wellbeing outcomes for everyone in Luton, targeting the most vulnerable and those at risk of poor health and life outcomes. And that is absolutely the key to everything that we're doing. So we are informed by data and by evidence. So you will see as we come to you and we talk, you know, regularly about the evidence base for all the work that we do. But we are also, as I say, linking in with what families, but individuals and residents are telling us. And we do that on a regular basis. So this is the Health and Wellbeing Board, where this strategy is going to sit. So it'll be this board's responsibility to hold the strategy to account. And you can see from our governance strategy, our governance process as part of this. We have a number of boards that sit under the Health and Wellbeing Board that will report in. So we will continue that process, but again, happy to hear views around how that works. As I say, it's going to be part of the LBC framework. The processes will learn from what we've already got, but also moving forward. And this is really an opportunity for you know, happy to hear any comments or questions, but just to bear in mind that there is that opportunity to also feedback individually. The process will be finished towards the end of the summer. We're hoping by September we will have a final strategy that will come back to this board at that time. Thank you. And any questions or comments?
Indeed. So Umi, go ahead.
I'm asking lots of questions today. Yeah, thank you, Elizabeth. I just had a skim through it, so I've not really read it in detail, but it was good to see the residents' responses. Interestingly, top themes: cleaner, safer parks. Someone said that's unsafe and dirty, and that's a common theme that we hear as councillors, and that's why it's a council priority now to improve those parks and green spaces. And the other stuff around the sort of obesogenic, the food environment, and the fact that takeaways are easier to access than healthy food. And that's why this has to be a whole system approach where we're working with the licensing teams and across the council to try and improve our food environment that has been a problem and has gotten worse year after year after year. So yeah, it's interesting to see. I guess my only comment on this resident survey is that you said you're consulting wide, but I noticed there's 58 responses to the survey, and I would be interested to see what the demographic data and makeup of that is, unless you're saying that there's 58 responses, but you're also using, because you're saying that you consult with the public on a regular basis. So you're using sort of wider discussions that the public health team have with the public alongside. And then I was also just going to comment, and I'll probably pick it up separately as well, just around the overlap and understanding between the sort of child-friendly Luton board and some of the objectives that we're developing with young people around healthy lifestyles, and that there might be a little bit of overlap here. So we probably need to pick it up separately around how we can bring that together. Yeah, and then I was just going to finally comment around the whole system, and it's really important that public health is seen as everyone's responsibility, and that we do find leads for those areas that are in health or that are in other departments within council, the social justice unit in particular, but all of those areas that are focusing on, for example, people in Gerard's department that focus on like the actual day-to-day of the building and all of that, and how we can get them to lead. Because if we don't get everyone involved, then it becomes the responsibility for you and the public health team, when it should be everyone's, including our partners outside of the council. Thank you.
Thank you, Councillor Ali. Absolutely, and I think I've just written down your points one by one, and to be honest, absolutely agree with you on all of those. I mean, specifically the parks and the food, which sits in under my remit, but also the children's health. And as you know, myself and Kelly are both sitting on Child Friendly Luton, so we are making sure that there's no duplication, but there also things don't get missed. And I think that's the key, because the Health and Wellbeing Board can't only look at adults, it has to look at children as well. It has to be a whole population and family approach, but we're absolutely aware that that Child Friendly Luton side is also picked up. So we are making sure, and part of our reporting includes across both. So absolutely, we are absolutely aware of that. Regarding the consultation, absolutely, back towards, I think, at the end of last year, we did a big consultation for women. We spoke to over 200 women, just stopped them in the streets, all across the town. We were in about, 20 different locations. Everything that we've done over the last year has really contributed to that. So this isn't just the views of 58 people who are, they're probably engaged people. We've been going out and really actively seeking and working with community groups. And yes, finally on the wider system, absolutely, and I was having a discussion just today around how we engage and work with all the wider parts, all the wider directorates, which we are doing. maybe it needs to come out more in this paper, but this is absolutely a whole council approach and a whole system approach, not just a council. This is about how we work together, but as wider. This is not just around public health. Absolutely, we can't do this on our own. So yeah, absolutely agree, and absolutely happy to pick up one-to-one if there's any of those specific issues, particularly around children, that you want to pick up with us.
And Kate, you want to add something?
Yeah, I just wanted to add as well that one of the things that we've learned a little bit from the previous population wellbeing strategy was that it wasn't particularly owned by health partners as their strategy as well. So a lot of engagement has been taking place with health partners, with PCNs, with the hospital, with some of our key, providers in that space as well, to make sure that they see what, the resulting health and wellbeing strategy as a true partnership strategy and not a council strategy. Okay.
Mummy, I think you had another question as well, didn't you? It's all answered. Okay, sure. Okay, cool. So if there, oh, sorry, do you, Raj?
Thanks, Elizabeth. Just to say, really pleased to see the focus on mental health under Start Well and Grow, so that early stages rather than a all-age mental health approach. So I'm really pleased to see that. Just in terms of health equity, care leavers is an interesting group that fall outside of the children's arena because they become 18, but are a protected characteristic for Luton, particularly. So just flagging, and I'm sure it's in your plan in how they're considered, and we promote equity and equitability around access to health and wellbeing support for them as well, please.
Yeah, absolutely, Deirdre. I'm really happy. If you want to put that consultation in yourself, that would be absolutely welcome. But of course, I'm really happy to take that back and ensure that we are including care leavers. Absolutely, really key group. So yes, if it's not explicit, we can make sure that we have reference to the needs of care leavers. It's absolutely a really important group.
Okay, go ahead.
Sorry, just to highlight the care leavers strategic goal 2, which talks about children and young people aged between 5 to 25, includes specific reference to care leavers. Okay, thanks. And also picks up on young carers as well.
Given that, Kate. Are there any more comments, contributions? Okay, so the recommendation is that the board reviews the report and the accompanying data which is being developed, and that the board contributes to the consultation. Thank you for doing that. The initial consultation stage has been broad, engaging with council and partnership boards that report, and partnership boards that report have contributed to the previous strategy, and through online and in-person discussions with residents at community locations and events. Wide consultation helps gather different views, and bringing those views together is resulting in emerging priorities that will be considered for inclusion in the new strategy. So thank you for putting that together, Hannah, and for presenting that. So we will move on now to 15. Sorry, Elizabeth, thank you to you. And we're moving on to Hannah now, who is online, and that's healthy ageing, I believe. Have I got that right?
Yes, thank you, Chair. So the purpose of this item is to present a new piece of work that we've been working on in the last 6 months around developing a proposed healthy ageing work stream and strategic plan. So in this item, I'll just present briefly the results of the scoping that we've been doing, and then it would be great to get from the board any views and strategic direction around where we want this piece of work to go, because it's still at an early stage. The background to this is that although Luton is often regarded as a town with a young population, the population projections into the future are that we're going to see the fastest population group in our older population. This is a population that already have quite poor health outcomes, so we've potentially got a bit of a perfect storm brewing of a growing unwell population who may well put strain on NHS and adult social care services. I think the other thing to say as well, just to be a bit more informal, is I think Luton's older population, I've been going out and speaking to people, they are a really valuable population in our community. There are a lot of people who moved here from all over the world at a young age, and they've stayed in Luton for their whole lives. And so their story is tied up with the story of Luton as a place. So I think they're a really a group that we should really be kind of cherishing and promoting, as well as the kind of the need and service arguments going forward. So just to draw your attention to a few things that have come up from the scoping. So on page 203, what we've identified is that at the moment, health outcomes for older people in Luton are quite poor. So our life expectancy is lower than the national average, and healthy life expectancy in particular, which is the average number of years you can expect to live in good health, has really dropped dramatically in the most recent data since the pandemic. So healthy life expectancy for women in Luton is now just under 56 years of age, which is significantly lower than the national average. And Luton is bucking the national trend in terms of women being having a lower healthy life expectancy than men. So we definitely have some work to do around really trying to delay the onset of ill health. The diagram below the healthy life expectancy showing the two curves again just shows that we're seeing an early emergence of age-related issues in people in Luton. So we tend to be about 5 years ahead of the curve in terms of emergence of long-term conditions, frailty, etc. We've looked at what's driving that. So on page 204, we've just got a summary of some of the things that are driving that poor ill health, starting from the building blocks of health. So things like we have a high proportion of older people living in poverty linked to low levels of employment pre-retirement. We have relatively poor housing stock for our older people. And then we're looking at, similar to the rest of the population, we have high levels of obesity, still a relatively high number of people smoking in this age group. And that results in the poor life expectancy that we're seeing, which is driven in particular in Luton by things like cardiovascular disease and diabetes. I also just wanted to draw the board's attention to the fact that although that's the picture overall, on page 206, the business intelligence team have done a really interesting population segmentation where they've clustered together the wards in Luton around similar groups of older people. So I think it's worth saying that we have some very different subpopulations of older people within Luton. So actually our largest group of older people in segment 1, who make up about a third of the over 50 population, they tend to be people living in some of the outer wards of Barnfield, Bramlingham, Wigmore, tend to be old people, predominantly white British ethnicity. And even though they're the oldest old, they actually have good life expectancy and a relatively low level of need. Whereas if we go to segment 5, even though those communities are younger, so in wards such as South, Farley, Biscot, they're actually showing equally high levels of need despite being chronologically younger. So I think we've done quite a lot of disentangling of, there's quite a complex picture in Luton of age, ethnicity and deprivation and how they interact. We started speaking to older people. So on page 207, I've just summarised what older people have told us. And I think the key thing to highlight really is again how people's, when I ask people about health, they don't talk about health, they talk about how they feel about Luton as a place, that they feel it's changed and declined as a town, fear of crime, green spaces, and people saying that they feel invisible and excluded, and saying things like people don't want to go into the town centre. So I think, as with all of public health, it's not just about health, it's about the wider determinants in the building blocks of health. I've looked at what we've already got. We've actually got a lot of provision in Luton. So on page 209, I've tried to map some of the many services that we already have. So I think we haven't identified any huge gaps in provision. I think it's more about making sure that the right people are getting connected to the right provision. And also some of our key provision is quite precariously funded. So it may just be about strengthening some of those connections. So what we've proposed is that we develop a sort of a work stream around healthy ageing in a strategic plan. So that's outlined on page 211 onwards. And I think some of the key things to highlight are that we're proposing that this should start at age 50, so ahead of that onset of ill health at 55 for women. And we have a set of work for 50 to 65-year-olds that's about prolonging good health and preparing for retirement and a good older age, and then a separate work stream that's for people who are 65 plus, which is more about enjoying your old age. We're suggesting that the work stream should address some of the drivers of ill health, particularly around poverty and deprivation, some of the health drivers, but also the key importance of mental health and social connection and preventing isolation and loneliness. And then lastly, one of the things we'd really like to do through the strategy is to raise the visibility of older people in Luton and to enable them to feel connected and valued by the town. So very happy to take any comments or questions.
Thank you, Hannah. Go ahead.
I fall into the older category. I just, very simply, how are you defining if somebody is healthy or not healthy? I mean, somebody can have a condition for which they are being treated, but live a fairly active life. So how are you defining if somebody is healthy or not? I take a load of tablets every day, but I've still got a fairly active life.
Yeah, that's a great question. So this data is taken from a national survey, which allows people to self-categorise whether they characterise themselves as being in good or bad health, and then they can choose which conditions they have. So you're right, there is an element of subjectivity in there as to whether people consider themselves to be in poor health or not.
Okay.
So let's keep guessing.
Are there any more comments, Kate?
I think, just building on that, Hannah, I think it would be useful to be able to make the link across, obviously, that self-diagnosis, but also we do have the data and the stats that show around actually some of the people living with multiple conditions in Luton and frailty coming earlier in Luton than it's visible necessarily in other localities. So maybe making that link across to the health data that we do have access to would be useful. I think the other thing that I just thought might be helpful as well is around, we don't really pull out dementia here, and there's maybe something for us to just pull out as a specific issue around mental health and mental decline and dementia as an issue for us to be aware of as our older population increases.
Can I come back? I think just coming to, I mean, for example, recently somebody said, well, a doctor said to me, that is an age-related condition. Here's a pill that will deal with it. So that then means you are like living like somebody that doesn't have that condition. So your life is fine, but yes, you have an age-related condition. Do you get what I'm saying? So I can be happy and live a reasonable life, but I have a condition which is defined as age-related.
So surely defining whether you feel healthy or not and having that more subjective is the answer, which is what we're doing. But yeah, no, we hear you. It's not ever as straightforward as a category. Go ahead.
We sometimes get feedback from areas where there isn't deprivation, but there are older people living in that community. So an example would be Sundon Park and Bushmead, which are, two average sort of areas of Luton, but where a lot of older people live, where they say there's no services they can access, they might be isolated, or services for exercise and keeping yourself fit. And I think it's because they're areas that there isn't deprivation, that the people living there feel that they've been forgotten about. Yeah.
I think that's a really valid and strong point. If I may, I just want to mention a body that I know that isn't listed in the partners in the document, and that's the University of the Third Age. And they're 30 years old this year. They're one of the most vibrant, active community voluntary sector organisations I've ever come across. And the ones in Luton are amazing. They've got 69 groups that cover 50 topics. That's from physical activity to, academic stuff. And many of them are retired professionals, but they cater for everybody. And they've always reached out to us to say we want to partner more with the council. We want to, create a partnership. And I think certainly we should be looking towards the University of the Third Age. We've got a lovely website as well, so you can see what they do. To cover things like loneliness and physical activity and, keeping us, our older population mentally engaged as well. And they've got so much to contribute. And some of them are there working with schools and doing gardening clubs and running things for the younger generation as well. So it's a win-win for us to look at that as a partner. And so that's my strong recommendation to you, that you look to reach out to them. Gina Inge is the chair, I believe, and she's always looking to expand. Very active. And hats off to them. It's not age, but it's just, having that passion for what they do hasn't slowed them down one bit. So thank you for that anyway, for the report. If there are no other questions or comments, sorry. Bev, did you have your hand up?
Yes, Hannah, the conversations we've had at the Health Equity Town Partnership were very useful from my regard, and I'd echo what Kate has said about dementia. I think that's a really useful point to develop from our point of view. We are looking at our own community risk analysis across Bedfordshire at the moment at Beds Fire and Rescue, so I'd appreciate a conversation about the data segmentation, because whilst people over the age of 65 who live alone are more at risk of fire, we're very interested in early interventions and how we might support those to really start to mitigate against the risk of the sort of more aging, sort of unwell population who we don't want to then have to work with on our adults at risk management framework. So perhaps we could continue that discussion outside this forum. Thank you.
I think Jill has a hand up as well. Jill, online. Can't hear you, Jill, if you're speaking. No, we still can't hear you. We can't hear you. Oh, hang on.
Did you get something then? Yes, a little bit.
A really tiny, squeaky voice. Sorry, Jill. Try again.
It's all right. Sometimes it kicks in as I start to talk. Is that better? I'll try anyway.
Just plow on.
Yes, okay. So I just wanted to thank Hannah for such a really comprehensive report, the like of which we have not seen in Luton before. And actually, we really should be taking note that regardless of how we're classifying healthy life expectancy, to see it falling so rapidly and being in the early 50s of age range for both men and women is a really significant problem for us. It's a problem for those individuals living and coping with those conditions that they feel is impacting on their life, because that's the definition, but also it's going to be a real problem for adult social care. We already see our demand being greatest demand being in working age adults with physical health conditions, not in the super elderly and or other conditions. And it's a really big impact on all of our health partners. So I really value this report because it gives us the opportunity to really focus and target what we need to do to support it. And there was some mention about dementia, which of course is really important, and we'll be developing a partnership dementia strategy during the course of this year. But I'd also just like to flag other mental health conditions which often accompany old age, which is depression. And depression and anxiety are the two highest factors of mental health conditions affecting the elderly, much more prevalent than dementia, that really impact on people's lives. And with a group which finds it stigmatizing and troublesome to reach out for support. So if we can all be mental health champions for our elderly residents, friends and neighbours, that would also be a really positive thing that we could do. So I just wanted to make that point because it is really, really vital. It's not just dementia, sadness, loneliness and anxiety about a world that's going faster than they've been able to live with before. It are real significant issues for these groups. Thank you.
Jill, thank you so much. That was very clearly and articulately put. Are there any more comments or questions? No. Okay, so thank you so much, Hannah. It was an excellent report, and you know we have to be really realistic about where we are and look at trying to find solutions. But thank you. That all is noted. So can I just just return to the recommendation that we review the report and offer leadership advice to help direct development of the Healthy Ageing Work Programme, and that will be ongoing. Thank you. We have a number of items for approval. The first one is item 16, and that's yourself, Paul Wagstaff. It's Luton Partnership Send Reform Plan, June 2026 presentation.
Thank you very much for this. I'm just going to share the presentation. What I'm aiming to do is just go very quickly through the major SEND transformation that's taking place nationally and what we've been doing in terms of preparing for this as part of a local SEND reform plan. We're about to begin probably the most significant shift in special education needs provision that we've seen for over a decade. And the current government have been putting many building blocks in place for this, going out for consultation. There are legislation changes already referenced in the King's Speech. As part of the major SEND reform, local authorities and councils were convened to pull together a local partnership inclusion and SEND reform plan. Luton Borough Council has been working with our strategic partners to produce a plan of how we're going to manage over this next 3 years to put the building blocks in place. The plan has now been submitted for sign-off by the Department for Education, and if approved, which we are expecting it to be so, it will release over £2 million each year for the next 3 years to bring in additional capacity to support our schools. What I'm wanting to share now is just an overview of the plan, the implications of this plan, and please bear with me and I will answer any questions at the end if anybody has it. The plan's being developed by all of our strategic partners because SEND is not an issue for a local council. It's an issue for our health partners, our council, our education, our social care, our parent carers forum, and all our partners in schools, earlier settings, and colleges who meet the needs of those children. So developing this plan, it's been quite crucial that we worked with everybody to pull this plan together so that everybody has had a part to play in it. Everybody understands where their views have been and also how our plan has reflected on their priorities. The key headlines of the reform, just this is a bit of a starter really, the key headlines of the National SEND Reform Programme is that mainstream inclusion is at the core of everything, that the needs of every child should be able to be met as far as possible in our mainstream schools. What it is doing is introducing over time what they call targeted and targeted plus individual support plans, which will replace education, health and care plans in mainstream schools over a period of time. It's also aiming to cap fees on independent non-maintained special schools to try and help reduce the costs, and also reducing and supporting the reduction of children travelling out of their local area for additional specialist provision by trying to ensure that those needs can be met more locally. The other issue it's trying to do is to help bring significant sustainability to a SEND process that reduces the significant financial pressures that actually many local authorities are struggling with as the number of young people with SEND and EHCPs escalates year on year. And by doing this, they're trying to provide a sustainable financial system for SEND. And what they've also put within the plan and the reform is an investment in early support and intervention, what they're calling the experts at hand. And I'll talk through that as part of our reform plan. Capital investment is preference for mainstream schools rather than expanding special school places to make sure that our mainstream schools have the capacity and the facilities they need to meet more complex needs as children come through. And again, the other key area is about creating those better connections, stronger connections, as my colleagues from Public Health have already mentioned around the Best Start in Life. the stronger connection between families, between the SEND, Families First, and the Best Start in Life strategies as well. Strengthen co-production of everything that we're doing to make sure that parent carers and young people feel engaged and that their needs are being followed through in terms of how they see them into the future. And in the future, EHCPs in the longer term will only be available for children who are educated in special schools. Within the expectations from our plan, this is what they've expected for this next 3 years, that mainstream inclusion is the universal expectation. So we built in the plan that that's the starting point, that all of our providers are inclusive schools and inclusive settings, and that the needs of most children can be met with the sufficient support that they need. All providers across all phases will have access to what we call experts at hand. In the main, they will be educational psychologists, speech and language support, occupational therapists, plus additional specialists, and these will be available free at cost, no charge to the schools or the settings, but their main focus will be to try and get that early help in before there is a need for a referral, to try and reduce the need for referral because they've got the capacity and the guidance to be able to meet those needs at the start. That greater coordination between Family Hubs, Families First and SEND, the expansion of inclusion spaces in schools with capital investment so that all secondary schools will have inclusion spaces where children can be educated as part of their inclusive package, and then all primary schools, mainstream primary schools, will equally over a period of time be supported to have inclusion spaces there as well. What they have done is put constraints on increasing specialist places for children by trying to put the emphasis on mainstream rather than specialist. And also the other key thing is building capacity on the front line through additional continuing professional development and training to make sure that our schools and settings have the expertise that they need to meet this need. All schools and settings will have to be part of what we call a local SEND partnership with a clear commitment to work with the local authority against our priorities on SEND, and also how we will then work with them to make sure that that partnership is successful and all schools and all settings are complying and working collectively together. And the other thing is around the financial sustainability over time. We've developed this plan and we've worked through all of our partners and had a whole range of engagement sessions during April, including all the settings and the groups that you see there. We've interviewed young people, we've had online surveys, and all of their sort of suggestions and contributions were used when we put together the plan that we submitted now to the DFE. We talked about the experts at hand. It's a bit complex, is this, but I'll just give you an overview. We have 5 neighbourhoods through which our current Families First and our schools working, and the North, West, Central, East and South. They've been in place for some time of these neighbourhoods, particularly around schools. And what we're working on is a neighbourhood model so that each neighbourhood has a SEND strategic partnership coordinator who will work to coordinate the experts at hand, the psychologists, the SALT practitioners, the speech and language, the Best Start in Life, the home visitors, and therefore we will also have some other specialists that are working across those 5 regions or 5 neighbourhoods, and they're listed at the top. We'll also, as part of the experts at hand, be drawing on expertise from our special schools and other services that we have to make sure that they're also part of this picture and build up over time a level of support to our schools free of charge and our settings and post-16 providers to try and get in early to support them. Although we've built in 5 neighbourhoods, because that's how we currently work, we're leaving things open during that first year to then look at whether we need to review those 5 neighbourhoods in line with any other change that are happening to the town's future neighbourhood structures, which may change. So we've actually built that in to the programme itself. We've got a 3-year plan. There's a lot of information on there, which I don't intend going through today, but I will highlight some points from there. So each of these 3 years builds on 1 to 2 to 3, with the intention that by the end of year 3, many of the building blocks and the capacity and the baselines are already in place to allow the rest of the reforms to follow through. But within these first 3 years, we're going to start off by piloting 10 primary schools with additional funding to trial alternative approaches to inclusion and managing children in early years and Key Stage 1 without the need to escalate to an EHCP. We've trialled this with 3 schools recently. It's led to about half of the children being able to continue in primary school without the need for an EHCP. And we're going to test that with a larger group to see whether that actually funds and sorts itself out and helps provide a model for all of our schools to follow through. We're introducing the early support, the capacity building through the experts at hand, and again, £2 million worth of investment each year for the next 3 years to provide that specialist support. We're also reducing out of borough placements. Over the 3 years, we'll be looking at creating a post-16 social, emotional, mental health provision within Luton so that our post-16 children with SEMH don't need to travel to provision outside of the town. And this builds on some capital investment into additional special schools, which is taking place in Luton over the next 3 years. A SEND partnership agreement, which will be based on all providers being inclusive, which will be a memorandum of understanding with transparency of data, with oversight and governance, so that therefore we can call out those settings that are not inclusive, but making sure that everybody within the town, all of our settings and schools, are openly cited on how inclusion is working across the settings that they're working next door to. Major professional development and expertise building in the programme, building the skills of professionals within schools to make sure that they also have the skills to be able to meet the needs of more complex needs as they're coming through. And the other key thing is around the major system review. We know that between different council departments and services and our health services, and even within health services, those data systems don't always connect together. So we're recognising that there's a lot of work needs to do to simplify that and to make sure that the information is there at the right time. And we've already started meeting with our health colleagues around how we can systematically improve the collection of data or the information sharing between tertiary healthcare with our community health providers and for children who've got quite complex medical needs, because sometimes the information isn't always present. But then ultimately, all of this is then supporting the council priority on reducing NEETs and those young people post-16 who are not in education, employment or training, and those who are moving into adulthood who are then economically inactive, who have SEND. So all of this is building up those building blocks to help us reduce that potential of what we have of young people when they reach the age of 16 or above, then struggle to know where to go as they transition into adulthood. And also part of that, which is a building on from that, is improving pathways into adulthood for our young people with SEND, with stronger training and skill development, both as they move up to the age of 18, but also up to the age of 25, and working with our adult skills to try and improve the training offer for our young people with significant SEND need. The specific new things within our plan, the local partnership agreement is one. I've mentioned that already. The access to that wider specialist support and advice and training being one. Capital investment to improve inclusive spaces and access in our mainstream schools. The Trailblazer projects with 10 primary schools to test that out. Better joining up of the processes, professional developments, and more children with SEND being taught locally to where they live. And one of the key things is that actually children who are living in a local area, if their needs can be met in a mainstream school, the question is raised, why do they have to travel and why do they travel to the other side of town to go to a mainstream school? Because actually there may be suggestion that that school is better at meeting your child's needs than we could meet them. And the whole point of this is making sure that if a child's needs can be met in a mainstream school, then they should be going to their local school, and all of those schools should be able to meet that need. And what will it mean on the ground, and what difference will we see? Well, for schools, they'll see themselves as part of the local partnership with common principles on inclusion. They'll have greater access to a wider range of specialist support and advice that they've not had before. They'll see capital investment into those schools to improve their access for inclusive spaces, resourcing. better joining up of those processes to speed up decision making, and greater professional development at all levels to build that capacity within those schools to make sure that they've got the staff that understand how to meet the needs of children coming through. Better support in place to support children in mainstream, and more children with SEND being taught locally to where they live. And sometimes we get the situation where schools who are next door to each other have an unequal number of children with EHCPs. And there's always a suggestion that actually one school advises the parent might be better going to the other school. But sometimes, because a school builds a reputation, parents themselves choose a school because that reputation in the community is so strong. So we need to even that out. And we've mentioned about the 10 primary schools. What will early years settings see? Well, they'll see the same about that local partnership agreement. They'll get the access to the specialist support. They'll see better joining up between home visitors, home visiting, inclusion practitioners, our health visitors, and the family hubs, so that the early settings will see that much better joining up of those processes, and also help in terms of professional development and supporting the transition for children with complex needs from early years into our schools. Again, with more children with SEND being taught locally. What will parents, carers see? Well, this is what we're aiming they will see, and this is what parents want to see. More involved in the co-creation of the support and seeing how their input has shaped and changed things. And we're actually also building within the first year of the plan a benchmark in terms of co-production, so that we're actually meeting national benchmarks, so that our young people and our parent carers are actively involved at the right time in developing the processes and developing the resources. They should see that support and provision in schools better responds to their children's needs. Should they see fewer children being asked to be on part-time timetables, or actually excluded, or suggested that they find somewhere else to go. Local schools being able to meet those needs and receiving the support that they need to help that. And the child feeling that they belong, and children being able to continue their education learning locally, even beyond the age of 16 years, which some of them cannot do at this moment in time. And parents should also feel that they're listened to, and that their children and their children's views are listened to, and they do make a difference. Sorry if I just apologise for that. Post-16 providers will see very similar in terms of that advice, etc., and the access to the support, but that stronger transition support for young people from statutory school age through to obviously the post-16 as well. And children with complex needs, again, being taught more locally rather than actually having to travel a distance. But placements are likely to change over the next 3 years. We're going to see a continued rise in EHCPs over the next 2 to 3 years, but there will be a slowing down with new requests in the early years and Key Stage 1 reducing. And that's our projections as we get more work done to try and look at the targeted and targeted plus to meet those needs without the need for escalation. What we'll see is increasing numbers of EHCPs managed locally and in mainstream schools and inclusion spaces as they're broadened and developed. What we will be doing is increasing our specialist capacity from about 1,059 as it is currently to 1,300, nearly 1,350 within the next 3 years. But also as part of that, reducing the number of out-of-borough placements. Greater equity in mainstream SEND placements, as I mentioned, and an SEMH post-16 provision locally, which we don't currently have. There are some risks in this plan. A significant surge in EHCP requests. We know that as changes in the law are being debated and coming forward, our schools, our settings and parents are quite anxious about the future. And so therefore we are seeing an escalation of people wanting to get an EHCP, thinking that this may be their last chance. So we're actually looking at mitigations to try and resolve that. Some of the experts at hand are in what we would call hard to reach posts, difficult to recruit. We recognise that, so we're looking at what we can do to mitigate that. Significant changes in the health structures regionally and personnel changing, and that local knowledge potentially reducing is something that we're aware of, and we're working quite closely with our ICB colleagues to make sure that that doesn't impact on what we're doing. Mainstream inclusion funding that schools receive might be seen as not being sufficient to meet the increasing needs that they have. So we've got to work with the department and also how we can broker and support schools in sharing some of this to make the best impact. And additional guidance required or expected from the department is not timely. We've had to construct this plan with very little guidance. The guidance has been forthcoming and been told it'll be coming in the spring. We're still waiting for much of that. Some of the guidance which we've had to assume has just arrived yesterday in relation to what inclusion spaces should look like. So we're having to rethink when we go out to ask schools and look at how we spend the funding about this. And there are other parts of the jigsaw that still are not in place. So we need to recognise that. The governance of this will be through the processes that we already have in place. So the dark blue on the screen here shows the SEND process. So we have a SEND reform delivery groups that then feed into the SRO, which is myself, and I feed into the SEND Strategic Partnership Board, where issues are resolved. We report on data. If there are issues that cannot be resolved, then we escalate them to the Health and Wellbeing Board or report up to here. But then also there is a side track of this, which is actually the ICB governance structures as well. So we can go across into that if there are issues that we need to follow through. Just to finish off, points to note, this is the beginning of a longer term transformation of SEND. The first 3 years is part of putting the building blocks in place. The plan is not aiming to address everything within the reform. It can only do a part of this, but the reform is actually at least a 6 to 10 year programme of change. There are still many questions that have not been answered yet, and we're still waiting for. The local partnership of schools around SEND is to bring a big commitment to all of everybody working in Luton around SEND to work together against common objectives. And the initial plan also prioritises attendance, reducing severe absence, permanent exclusions and suspensions, and also part-time timetables by making sure that the range of children's needs can be met in school and in settings. And the experts at hand guidance has now been published, but as I say, we're still waiting for further guidance coming through. That takes you through very quickly through where we are with that, but I'm more than happy to take any questions if anybody has any. Thank you.
It doesn't look like there are any questions. I think primarily this was to note, but just to say a huge amount of work has gone into this. And, you know, given our need, it's critical for us to get this right. And I think doing it so that we can deliver for our communities and young people in the best possible way is a priority for us. But yeah, thank you for presenting. And it is to note, so we will take it as noted, and we look forward to future updates. Paul, thank you so much. Very
Thank you very much.
Thank you. So we're going to, this has been a really long meeting, and we've got 20 items on the agenda, but you're pleased to hear that we're coming close to the end now. But just to say that items 17 and 18 are Better Care Fund related, and item 17 and 18 will be taken. I'd like to suggest Jill end to end, if that's okay.
Yeah,
because they are to agree, aren't they? Are you happy to do that?
I'm happy to do that. I've got some slides if you'd like me to do them, but to be honest, they have already been signed off outside of the meeting. So they're here for the formal sign off, but they have been signed off because they've already been submitted. So it's up to you if you want me to take you through.
Could you just speak to them briefly as an overview, and then we'll move to the next point. Thank you.
So let me just. Okay, so as we mentioned, this is these slides will talk to both agendas, and this is the deadlines that we had to meet. So submitted to NHS England on the 19th of May, our assurance for last year, and also submitted on new narrative plan. So the interim sign off, it has been signed off by both chief execs, finance directors, strategic group, the Health and Wellbeing Board, and designated signatories. So this is just a quick recap on the end of year metrics, which are the ones in green and amber, and you can see that we predominantly met the metrics for the Better Care Fund. in 25-26. We didn't quite meet our metric regarding long-term nursing and residential admissions in Q4. However, this is largely because we have changed, that the Department of Health has changed the way it collects its data. And actually there are some data anomalies which made it very difficult for us to properly forecast what the measures were, and how they measured the people changed during the year. So it was a little way off, but it was actually, you know, broadly in line with what we'd expected. And then we have targets for 26-27, a 1% reduction on emergency admissions, and an increase on the number of people who will be discharged without delay from hospital. And we're still working on the residential and nursing care metric because we need to correct our data anomalies, as I've mentioned first. So in terms of the next year, the key success for integration in 25-26 is largely the same as it will be for 26-27. There are some challenges for further integration, particularly around moving to from a pan Bedfordshire perspective to a wider ICB. And we have been working with the ICB on looking at pan Bedfordshire schemes and to ensuring that all schemes are relevant and giving us best value for money. The budget is largely the same across the 2 years. You will see that there's only been a marginal increase for 400,000 for 26-27. The better care objectives now continue with the same theme from last year, shifting from sickness to prevention, supporting people to live independently, and the shift from hospital to home. And it also needs to be noted that 26-27 will be a transition year for the BCF as it moves to becoming a stronger enabler of neighbourhood framework. However, I think that Luton is really well placed to be demonstrating that our investment is based on neighbourhood delivery and supporting people to live well in the community. 2 of the BCF metrics continue into 26-27 with a further 2 recommended metrics, which Luton will be monitoring, but is not a national requirement to submit data to set a target for those as yet. This slide gives an overview of the schemes that we invest in. So the top schemes here are related to the NHS minimum spend. We have a small grant between the ICB and the local authority, which supports short-term packages of care. And that's finite money. Once we have spent that, then that will cease, but we're okay for the next year. And then for the local authority better care element of the Better Care Fund are supporting these activities here, which you will see very much all of which support community work. So in terms of next steps, as we mentioned, the national submission was on the 19th of May, and the Health and Wellbeing Board approval today. NHS England panel is on Friday, and the full submission is the 29th of June. So we would expect to get our letter of approval in August. We will continue to monitor and review during the course of the year as per the schedule described. And on that note, I will end my presentation, but happy to take any questions.
Are there any questions or comments? Okay, thank you. So just to say, we are going to approve the Better Care Fund end of year template for full and final submission to the Better Care Fund Board and the DHS. Do you agree? Yep, thank you. And for item 18, we have reviewed the Better Care Fund plan and numerical template. And do we approve the 2026-2027 BCF narrative plan and numerical template for submission to NHSE. Thank you. So we're going to move on to item 19, which is the membership of the Health and Wellbeing Board. Mary.
Thank you, Chair. This is just an update report on the revised terms of reference to reflect the configuration of the executive membership and portfolio content, which changed from when the structure was changed, and also at paragraph 9 for the amendments to the memberships in terms of the change of organisation titles and the members who will be on here as named substitutes. Thank you, Chair.
Thank you, Mary. And finally, Health and Wellbeing Board Draft Work Programme 2025 to 26, which is at the end of our large document. Do we approve of that? Thank you. Mary, do you want to speak to it?
Can I just make a very quick comment? I don't think the Health and Wellbeing Board has ever had an agenda this long, but I think previously when it has, we've had the approval to note, and then we separated it. So some of the to note reports, we took them as read. I can't remember what it was. I don't know if you remember more on that, but at times when we had loads like this, some of them were presented with questions, some of them we took it as read and noted it, and maybe we need to try and go back to that. So, because I think what happens is if you get an agenda that's this intense, has really important things that we need to discuss, and it comes towards the end and then gets really long.
That's noted. Thank you, Amy. So we don't have any private items, so I thank you profusely for your patience, for your contribution, for being here for 2 hours, albeit we've got aircon. It's very hot still out there. Stay hydrated, and we'll see you at the next Health and Wellbeing Board. And thank you for all your contributions. Good evening.
All right. Thank you, Chair.